Our company manufactures custom membrane switches, labels, and overlays, and we also offer a variety of services including design and engineering, rapid prototyping, and assembly of the products that we sell. We sought to reduce the labor related to entering work orders and purchasing dies. We also focused on reducing the lead time for completing quotes, proofs, and pre-production work once the proof was approved. 65% of all the work we produce are for repeat orders. If we could streamline and reduce the labor associated with processing this large amount of work, we could focus more on our customers' satisfaction and also get the jobs to production more quickly. We developed a packet of reusable standards for each part we produce, which allows us to save processing time each and every time that job repeats.
One of our clinical pharmacists went to a conference in 2016 where there was some initial data presented from the city of San Francisco about rapid start of medications as soon as a diagnosis was made. So we turned around and realized, okay, if we start the medications on day one, we can drive the virus all the way to a level that is suppressed significantly faster than the way that everyone was doing it. We have now shrunk that in half.
Adding the rapid start process actually takes some of the stress away from the patient. So instead of coming in and having this long drawn out, like we said before, almost like a 90-day course of visits and testing, they get all the support they want in basically a 4 to 5 hour stretch. On top of that, it was a good chance for us to focus on the use of our quality tools and our ability to really streamline our process.
Our issue that we were facing for the plant, we have profit and loss targets that we're looking to achieve. Since we're a cost center, our P is really productivity. The first half of the year we were seeing significantly lower yields than what we had planned. On average about $50,000 a month we were losing in yield. So our objective there was to find a root cause and understand where the losses were really coming from. The cost of the material is really the important delivery for our internal program teams. And when we look at how we can keep the costs of production down, again, it's bringing that much productivity back to the business. About $50,000 a month higher than planned, which is bringing much more productivity back to the business than expected.
In this specific project, we addressed the potassium administration in our inpatient facilities to make sure that we are safe. Potassium is a very important element in the human body, especially for cells that conduct electricity like nerve cells and muscle cells, and if the level is too low or too high, it may cause some significant dysfunction in your body. And although we provide potassium more than 1,000 times a week in our hospitals, every other month the level becomes too high in this process. And that was our target of our intervention, is to keep our patients safe from this very rare complication of a very frequent and necessary medical care intervention. The three key elements, I think, were to have a clear and measurable goal, is to rely on teamwork and get expertise in health informatics and process improvement. So once we achieved the improvement and once we eliminated these high-risk scenarios, we wanted to make sure that is going to keep happening. And I'm happy to report that for a year after the project was completed, there was not a single event when a patient received high-risk medication for potassium replacement. In this process, we created an EMR alert that pops up for the nurse when they give medication. And we are very aware that too many alerts may have some complications. It is very important that we use the EMR to keep our patients safe, but also to keep our clinicians sane and empower them to provide the right care rather than just throw alerts at them. And I think this was a good example of how we did that. It was effective but also efficient and very well received by our end users and our clinicians.
So clients are required by state and federal law to post specific labor posters on their work sites. Paychex spends over $1 million annually to provide paper labor posters to our new clients. But what we found through our sales representatives' feedback, through listening to sales calls and from other investigation, was that not all our clients found value in paper labor posters. Some clients had virtual offices, such as event planners and construction contractors, and didn't have a place to post posters. Other clients preferred to get their information electronically and self-serve it as was convenient to them. So the project was really focused on two different aspects. One was to reduce the overall expense to the company, and the other was to be able to service our clients who preferred to self-serve in a better manner. We agreed on a release schedule, and we went forward with all teams contributing to the release.
We hold the patient experience as the highest priority at Newark Wayne Community Hospital. As a part of Rochester Regional Health, we have 5 acute care hospitals, and Newark Wayne has a team that's dedicated to the patient experience. What we found was that our patients are replying to surveys, and we're not getting the replies back for up to 3 months' time. And we felt that the biggest opportunity that we had was to be able to address patients' needs in real time. So we took on a project that looked at how we could get our patients' experience captured while they were in the hospital. We worked with a vendor that was able to connect with our electronic medical record and be able to send a text message every day to our patients asking the simple question of how their care experience with us was for that day. And what we found was that many of our patients, although we may have been giving it our best, the perception that they had of our hospital was not what we wanted it to be, and we wanted to change that. We worked with our senior leadership team and our program manager for the patient experience, and we looked at opportunities using a tool, the DMAIC tool, to be able to identify what the best intervention that could actually help us impact this.
Well, we were challenged by management to implement a process called Visual Scheduler. And what that is it's a scheduling system within our MRP system. And to accomplish the visual scheduling of our manufacturing processes, we had to go in and make changes to the MRP system, primarily in the way of how the employees punch their work into the MRP system for the printing processes. The biggest problem that we were trying to attempt was the on-time delivery. With the accurate scheduling, we could then predict our delivery and performance dates to our customers. We used many of the quality tools, the Lean Six Sigma quality tools, and applied that to our problem situations. And using those methods, we were able to achieve the end result of the accuracy in the time card reporting.
So Highland Hospital is a 261-bed acute care facility. We specialize in orthopedics, bariatrics, geriatrics, and women's health. We wanted to address the number of late trays that we were sending to patients. And a late tray is any meal tray that is delivered after a normal delivery time. Obviously, we wanted to reduce waste and cost, but we also wanted to improve patient satisfaction. We wanted to get the right food to the patient at the right time. This would also increase our employee satisfaction because it would reduce processes and steps. And then we wanted to have consistent messaging across the hospital. We did process mapping, brainstorming, prioritization of solutions, and then a plan of communication. Consistent monitoring is very important for sustainability of your outcomes. And by, I think, involving the key stakeholders from hospital-wide, they really bought in, and they are the ones that came up with the solutions to what we were looking for, and so that will also help with sustainability.
When I took over leading the customer services organization approximately 2 years ago, one of the first questions I naturally ask whenever I walk into an organization is around voice of customer data. So as I walked into the organization, the TCS organization, my first question was, how do we capture our customer experience? And I was met with a wide variety of answers, about 6 different processes. Some were paper copies, some were verbal, some were stored, some were scanned, some were used for recognition. Not many were used for actual feedback to understand, again, what our customer is experiencing, how we can either improve support resolution to issues, or again, take information back to even our product development organization to better our products going forward. The team then came up with a new process, electronic process that's able to use an iPhone and could go through a website and also could go through hard copy if needed. And then ensuring that we've got a process to bring it back into a data warehouse where then we can action it as it comes in. So we did have a gentleman, Jason Becker, who was going through his Greenbelt certification at the time. And as they worked through, I think there was just really some great discovery that was happening. And then when we got through to control, and we're actually able to utilize the data warehouse and move it into a data platform called Tableau, we all now have instant access to this customer satisfaction data, and the team can now utilize that within their day-to-day business.
So given the about 800 and more ischemic stroke patients that we see a year, we wanted to look at improving the door to treatment times for these patients. It could be treating them with IV alteplase or treating them with a surgical procedure called an embolectomy that removes clot from their brain.
Stroke patients it's a time-sensitive disease, and patients with stroke have an opportunity to be treated with the medication or surgical procedure that Sarah mentioned, IV alteplase or mechanical thrombectomy. But we know that if you treat people faster, then their outcomes are better. So you have a higher chance of having independence after a stroke if you get one of these treatments in a very timely fashion. We talk about it in terms of time is brain. The longer that you wait to be treated or the longer treatment takes, the lower your chances of a really good outcome after a stroke.
So we first started with a lean team to look at improving the times, and we started with a process map, just kind of drawing out what our response looked like to stroke patients coming in the door. And we also identified at the table the opportunities that we could just quickly improve, just do it, they call them. And these were opportunities to just improve quickly that provided benefit without too much work involved. And then we took a look deeper at the process map and identified ways to improve along the path of treating a stroke patient.
The improvement opportunity that our team addressed was the CMS 5-star rating, specifically the quality star rating component, with the goal of achieving 5 out of 5 stars, which is also one of our core values. Our team utilized Lean Six Sigma methodologies for improving and addressing the 17 CMS 5-star quality measures, specifically developing best practices for pain, pressure ulcers, UTI, catheterization, falls, and activities of daily living.
So we started looking at the order fulfillment process, which is a very large process, so we really scoped it down to the inquiry to quote to quotation section of that process. And we had recognized that there was a gap between our current results and what the customer's expectations were. We assembled a team from a half dozen different departments. It was a cross-functional team, and they looked at the quotation process. And it seems, the quotation process is pretty simple. You get the inquiry to quote, and you quote it. Well, they mapped it out on a whiteboard, and it was very eye-opening. From that exercise, they were able to come up with a list of possible improvements. And one of those improvements was the triage process, what we call the triage process. Where most triage processes look at the urgency of something, our triage process looks at the complexity of incoming quotes and categorizes it by how difficult is it to do. So by categorizing these quotes into simple or very complex, we're able to fast track the simpler ones and really making a big impact. The results were really incredible. For quotations, on the simplest quotations, we brought the average lead time from 3.5 days to less than 1 day. And on average, with all complexities, we were able to cut lead times in half. And then the quality improvement was significant. We were able to reduce errors by 40%.
What we noticed was there was an opportunity to reduce the risk for infections for our patients. There was surgical instrumentation that was making it down to the operating room. That's something that what we call bioburden, which is a contaminant from the case prior, blood, bone, tissue, things of that nature. We definitely took a team approach. It was myself and quite a few other individuals from the perioperative team. We had leaders from the OR, leaders from sterile processing department. We had a process improvement coordinator that really helped us along the way. We used many of the process improvement tools that our coordinator had in her toolkit, high-level process mapping, root cause analysis, solution selection matrix. It just kind of clicked one day, why don't we take our current audit and move it down to where it really should be? And we are now able to hold everybody accountable, and we have multiple audit points to really double check our standards and our work.
What we identified we needed to do was to get our buses to be more reliable for our customers. Our customers build their lives around our schedule, and the goal was to, regardless of weather conditions, traffic conditions, how do we get the bus to show up at the bus stop when the customer is expecting it to? We put together a cross-functional team and said, what are the problems we're not understanding? We taught them Lean Six Sigma tools, a black belt. We trained green belts. Everyone on the team became a white belt. We collected data, and using that data, we began to make adjustments. We began to see improvements. And it really took listening throughout the organization to find out sometimes the scheduling department had to do the schedule a little bit differently. Sometimes people who are monitoring the buses need to be a little bit more proactive. We put systems in place, automated the data collection, and put new technology on the buses and back at the radio control so that we knew in real time where the bus was and could make adjustments in real time, not wait till the end of the day.
The decathlon was a project that infection prevention came up with.
Everyone knows the Olympic decathlon, but to decath a patient means to take a catheter out. And remember, taking catheter out is the best way to avoid a catheter-associated infection. So that's how we came up with the name, decathlon.
We educated them about using alternative devices instead of using a Foley catheter so that they had something else to use. So we targeted those 6 units, and then we decided to come up with a game with this. And then we went up to the floor and introduced the idea of 5 different competitions in this decathlon, and they included CAUTI incidences, so the number of infections they had on their unit. We also looked at external device use, so that was our alternatives to what a Foley is. We also looked at Foley days, so we wanted to see that number decrease was the goal. We also looked at hand hygiene compliance, as that is the #1 way to prevent an infection. And then we also looked at people's participation into the project, and we took that into account by developing a CAUTI bundled ticket, and on this little ticket stub it had different questions on what you should be assessing with your patient every day. And we did this for 4 weeks, and then at the end of the 4 weeks we had a track board, and you could see where your unit was as they were achieving these different goals. So multiple units had great success. We had lower infections that entire month than we've had previously. We had increase in hand hygiene compliance, a decrease in Foley catheter use, an increase in our external device use, and we really had engagement.
The decathlon caught fire in a way I've never quite seen before. The decathlon ended 6 months ago, but the staff are still talking about it. The staff are still following those best practices. We implemented versions of the decathlon at all the acute care facilities in our system, and all of them had the same success.
So the primary improvements that we made as part of this project was to locate the same patient education information throughout all of our care settings. We created a page that has photos of how to use the metered dose inhalers. And then we also developed a video on how to use metered dose inhalers and spacers for asthma medication. And what we wanted to do was have it be an interprofessional education tool. So that video is also on YouTube and can be accessed by patients and families, primary care providers. And the last thing that we worked on was sharing a document that shows all the different types of asthma medications that are prescribed. So we have a photo page of what all the medications look like to try to reduce the confusion. The improvements that we've seen in this project, the primary one is reducing our readmission rate after a patient's discharge from the hospital. And we were able to reduce that rate from about 7% before we started down to 0. So we've not had any 7-day readmissions since we've worked on the project over the last year, and we're really happy about that.
So we identified in 2011 an increasing rate of infection with C. difficile. C. difficile is a normal part of your intestinal flora, but when your body changes either through antibiotics or other issues, it can become harmful to patients. And so this infection, these hospital-acquired infections, would start usually 2 to 3 days after they were admitted to the hospital, and we saw this rising rate, about 1.77 cases per 1,000 admissions, which was above the national average and concerning. So we felt that was a critical issue that we needed to address and wanted to get that rate down. So we put a multidisciplinary team together, and the very first thing we did was examine our cleaning practices and examine the room-to-room activities of our staff that went in and engaged with the patients. And so we did rapid PDCA, or plan to check act cycles, to go in and make a change, monitor that change, and then really determine its effectiveness. So it started with room cleaning. It started with education. We knew that the other part of this most important feature of preventing any infection is hand washing. We acquired a UV light cleaning system that actually goes in the room and kills bacteria through UV light. And we determined that the one piece we needed to add was antimicrobial stewardship. And that's when we really did start to see the downfall of transmission into the hospital that's led us to today, which is one of the lowest rates in the region and country.